I would like to call Dr. Gomez Sancha for his presentation concerning HoLEP.
Thank you very much. So, thank you for the invitation. I think Dr. Andreu is pushing very hard in Greece to move things forward, and I congratulate you for the effort and the drive to take the effort to organize such a meeting. And thank you, Dr. Bekos and Stavros, for everything as well. I'm going to start by, do I control the presentation or? Yeah. Okay. Why would we adopt anatomic enucleation of the prostate? We know that it does relieve bladder outlet obstruction better than TURP. Patients get much better symptomatically. We have reduced bleeding, shorter catheter time, shorter hospital time, superior catheter-free rates in patients in retention. It's highly effective in men with impaired bladder contractility. It's safe and effective irrespective of prostate size, durable, etc. So I think it is a no-brainer to adopt an enucleative technique if you're dealing with patients with BPH. But there are many challenges. When you do TURP and open prostatectomy in a department, it's very difficult to start. And I'm going to comment not only tips and tricks on how to do the operation itself, but also how to convince the hospital management, how to kick off your experience, how to learn safely, and then some other details that I think are interesting. Of course, if you want to convince the hospital management, you have to show them some of the studies that show the clinical benefit, but also the economical benefit. Purchasing a laser, purchasing the equipment can be expensive, but it pays off with time. Of course, you cannot approach the manager and ask him for money, because this is usually the response is going to be no. I think you have to imagine how your department activity is going to change if you start doing enucleation. So most patients will go home before than 24 hours. You don't need ITU. You don't need to cross much blood before the operation. You'll have a lot of beds free for oncological procedures because the turnover is very fast. It's important to communicate this because then when you make the numbers and when you realize that the degree of change that you're going to have, it starts looking like a little investment for a big benefit. Also, of course, it's important to budget for the learning costs. You need to budget for visiting another center, for learning, maybe bringing someone to help you when you start. Also, many people have this idea, if I do, I don't know, 2 TURPs every week, I cannot afford to buy a laser when you do your business plan. But of course, the moment you start doing HoLEP, you get more and more patients coming to you. So you have to have the confidence that the number of patients will grow and you will be able to pay for all this. And my advice is I think this is a surgery of maximums. You should have a very good camera, very good instruments, very good laser. So try to buy the best equipment you can. Also, for example, if you try to do HoLEP in your hospital and you're doing your first case, when you start doing this, there's going to be a lot of attention on you. And then the operation will take 3 hours. The anesthetist will tell you, you could have done 3 open in the same time, and then the manager will be discouraged. So I think it's very important to bring in someone who is very good at doing it so you can show the procedure to the nurses, to the hospital management, to the anesthetists, and they will love it. And then, of course, when you do it for the first time, they will understand that you have to learn, but already they know how the treatment looks like. Also, how to learn safely. I think there's never been a better moment to learn. I think you have to have commitment. Everybody I know who does enucleation had the commitment to learn. They wanted to learn. Every reasonably apt surgeon can learn. It's not a surgery for expert surgeons or superheroes. It's something you can definitely learn. It's important to understand the procedure because if you understand the procedure, it's actually quite easy to do. So the difficult thing is to understand the anatomy. We have never been there. When you do TURP, you have a lot of experience with endoscopic surgery of the prostate, but you don't know the anatomy. So there are many videos online. You can visit a center of excellence, and it's very nice when you do an arrangement, so someone will come to you not only once, but many times. So that's why I tell you, budget for paying someone to come, pay for his trips, make an arrangement so he can come, I don't know, 6 months, once a month. So you can do the easy cases, he can do the difficult cases, and then you will succeed. It's also important that HoLEP is not a solo operation. You need nurses that can help you, who understand the morcellator, who can assist you properly in the operation. So you need to train your team and, of course, choose the easy cases. So when I started doing enucleation, I think the most unattractive aspect of enucleation was the risk of incontinence. You know, there were many papers showing, I don't know, 29%, 25%, 36% incontinent patients after 1 month, and this would take a long time to recover sometimes. And of course, it's interesting that these patients are incontinent, but then they seem to get better over time. So probably the way enucleation was being done, the sphincter was not irreparably damaged. And I worked with Tony Mundy years ago, and he would say that only God can make a sphincter. So, well, the thing is that over time we have understood more and more that the sphincter is a complex structure, and there are sphincteric fibers that go all the way to the mucosa. So the lisosphincter has these circular and longitudinal smooth muscle fibers, but they go into the mucosa. So the mucosa is part of this mechanism. Also, we understand a little bit better the anatomy, how anteriorly the sphincter is more proximal and posteriorly it's more distal. And really, I think we have come to understand that when you do the classic detachment of the lobes without looking at the sphincter, you get this mucosal curtain. You know, this is what I call the infamous mucosal curtain. And of course, if you think, where is this curtain coming from? Well, this is the mucosa that was already attached to the sphincter. So when you go with your endoscope and you dissect blindly in the apical area, you rip off the mucosa from the sphincter, and then, of course, the sphincter mechanism is damaged. Why do they recover continence? Probably because the mucosa grows back over time. So we came, you know, it's been a long road, but we came to the realization that we need to protect the sphincter's mucosa to get good continence. So the challenge is enormous sometimes, because we have a little hole, there's the sphincter, and from there we have to mobilize the adenoma and release it around without damaging the sphincter. So I think it's important to reflect about this. And when we started with green light enucleation, we used to do this initial scoring of the mucosa between the sphincter and the apex of the prostate, and we found out that the rates of incontinence we had were very low. So when you do this initial white line, I think what you're doing is you're protecting the mucosa, and you're helping that at the end of the procedure you will have a sphincter that is covered by mucosa. So the technique, the way I do it now, is starts by scoring the mucosa, then localizing the posterior plane, developing the posterior plane, and then, of course, it's important to mobilize the apex. So it's not an immediate apical release, but it's more a progressive release that very carefully goes into the lateral plane, deepens the dissection a little bit towards the bladder neck. But before continuing towards 12 o'clock, you may have to make sure that you cut the attachments of the sphincter with the apex before continuing with the dissection. And it's incredibly useful to cut on the tissue. Sometimes we have to cut on the adenoma in order to get access to the plane. Some people think if you cut into the adenoma, you're going to leave tissue, but then this is an access incision that has allowed us to do this apical liberation very, very safely. So when you have to cut the 12 o'clock attachment, you see the apex progressively is mobilized, the apex descends, and then when you have to cut at 12 o'clock, you can initially cut carefully horizontally below the sphincter, and when you pass the landmark of the sphincter, then you can try to go up all the way to get all the adenoma out. One of the nice things of the en-bloc operation is that the space that you are irrigating is very small. So if there's bleeding, you will wash it out very clearly. You know, when you do the classic incision technique, there's going to be bleeding from the mucosa, and this blood is going to go into the bladder, and then it's more difficult to wash it out. So working in this little space can be sometimes a little bit uncomfortable, but of course visibility is ideal. Also, as I have tried to depict here, the adenoma mobilizes with the movements, and it allows you to reach the bladder neck anteriorly and then posteriorly, and then of course send the adenoma in one piece towards the bladder. Tomorrow we will have more hands-on experience on this. But the idea is that at the end of the procedure, instead of having this mucosal curtain and the deepithelialized sphincter, except at 12 o'clock, you have a completely epithelialized sphincter that will ensure that patients are continent. I think one of the problems, the lack of evidence with BPH procedures, is that following the patients prospectively is a pain. I don't know, you've made studies, and it's really difficult. You have to spend a lot of time, a lot of resources. So this is a prospective evaluation we did in 80 patients, and you can see the prostate volume. Prostate volume was about 86 grams, went down to 20 after the operation. The PSA went down to 0.6 after 3 months from 3.4. The flow rates increased very nicely, but the incidence of stress incontinence was pretty low, very similar to the preoperative stress incontinence rate or incontinence rate in this patient. So for us, it's now a rare occurrence. And we're not the only group that sees this. This is a Chinese group. They compared 3 different en-bloc techniques, and they realized that their rate of incontinence postoperatively was very similar to what we got when they use a technique very similar to what I got. And you can see that even they copied my drawing. So it really works. It's important that we have to discuss tips and tricks. Everybody asks me, what settings do you use? And I like to tell this story. I like drawing, and I'm not very good, but I watch all these artists who draw very beautifully, and everybody asks them, what pencil are you using? No, like if the pencil was going to make a difference. And laser settings are probably very important for stones, because more or less everybody uses the fiber in a similar fashion. And but with BPH, I think it's not only the laser settings, but of course the working distance you use. You know that the effect is going to be different depending on the distance. If you're too far from the tissue, there will be no effect. If you get closer, and this is with a classic holmium, you will get a mechanical effect that opens up the plane. Then you can have coagulation and mechanical effect, and then a disruptive or cutting effect. Now we have more complex pulse modulation settings that provide dissection and hemostasis. But of course, the working distance is important. Then, of course, as you can see, during the operation, the fiber moves around the adenoma. You can see the line. You have this MRI image in your mind. So these lines are quite easy to follow when you do an en-bloc technique. But of course, you can move faster or you can move more slowly. And that will also condition the amount of dissection you get, the amount of coagulation you get, the quality of hemostasis. So the surgeon is going to be responsible for this effect. And then, of course, to me, it's very important, where do you aim your laser? Because we are dissecting the plane. Initially, the prostate angles open up and then they close. You know, you go up and then you go down and then you go up. And then, of course, your aiming in relation to the line of dissection is going to be super paramount. So, for example, I recommend at the beginning of the operation, aim towards the line. But then if you want to, take the curve, like the motorbike, the guy on the motorbike, you have to get closer to the adenoma. And that's because if you fire You see, like below, you see, if you fire against the line of dissection, when the plane is changing the angle, you can easily get into the capsule. But if you fire a little bit closer to the adenoma, you will still dissect the plane, but you will not harm the capsule. Also, it's interesting when you do a block enucleation, often you find adenomatous nodules. Sometimes these nodules grow into the capsule, and some surgeons just cut through them and leave the nodule there. But I am in favor of removing these nodules. I think in the spirit of HoLEP, we shouldn't be leaving nodules. Of course, probably they can condition a retreatment, but when you remove so much tissue, probably it's unlikely. But I have seen some cases, and I'd rather recommend to remove these nodules. Also, one of the advantages of the block technique is that you don't need even to go in the bladder before you start. I mean, you can start at the apex. So when I see a very big gland with a big middle lobe, I don't even enter the bladder at the beginning. I start my dissection. And in America, it's very typical that they do perineal urethrostomies, because when they don't reach the bladder properly, I had never had to do it because of the block technique. So normal scopes tend to reach. Probably patients with penile implants are an exception. And then many people tell you, if you do en bloc, it's going to be very difficult to flip the adenoma into the bladder. But of course, sometimes it is. But of course, if you rotate the adenoma carefully, so one of the lobes goes into the bladder, and then you follow the same direction to push the other adenoma, then you will be able to flip most of the adenomas. Otherwise, you can split it at the end, or you can do intracapsular morcellation. And of course, you will do perforations when you do HoLEP, but the idea is that you want to detect them early, and you don't want to do big perforations. So you have to control the way you use your energy, so the effect is soft, and you don't stay too long in the same spot, getting very deep, but you do a very smooth effect. And of course, you have to correct the plane so that you aim your laser inside the line of dissection a little bit, or outside when you find the nodule, so you adapt to try to avoid the deep perforations that could be a concern. Regarding the UOs, I think it's important to visualize the UOs to avoid damaging them with the laser. I think with green light, probably the deeper coagulation of green light might be a little bit more problematic. And if I saw some obstructed ureters, and I heard about cases of obstructed ureters after green light damage. With holmium, I am a little bit less worried, in the sense that holmium penetrate much less, and I think the tendency of these UOs to contract and obstruct is much less. So actually, if I do a partial lesion or I get very close, I usually don't do anything, just monitor the kidney of the patient, and most of the times, I think up to now, patients do well. Morcellation is another, challenging part of the operation at the beginning. It is a teamwork, and it is safe, providing you stick to the rules of morcellation. And more or less, it's important to have it ready from the beginning of the procedure. You have to keep water flowing in. That's why you rely on other people to do that for you. And you should only morcellate if you have good visibility. Keep the mouth looking up, and keep it in the midline. And of course, this dance, the drawing that I show you here, is that where you lower your hands so the tip of the morcellator goes up away from the bladder when you're going to activate the morcellation. And then a reflection in your learning curve. It is always safer to put a catheter and return another day. The patient will never be angry with you if you tell him, I had to stop because it was not safe to continue. He will be grateful. Maybe he doesn't like that. He will have another go, a second stage to finish the operation, but that is always better than having a big complication. So this is a nice thing that you have to have decided before the operation. So to finish, I think we live in a day where there are new technological advances, the new lasers, the thulium fiber, the hemostasis is amazing. There are differences between the lasers, but There are now many morcellators that are quite fast. The endoscopes are getting thinner, and the surgical technique has changed to make it easier to perform, and I think easier to learn as well. So just do it. And this is my talk. Thank you very much.
Thank you, Dr. Sancha, and thank you is not for your speech only, but for everything, because me and I believe many urologists are obliged to you for all the effort you have put to explain the technique, to train other peoples, and yes, thank you.
Thank you very much. Thank you. It's my pleasure.
So, do you have any questions?
Fernando, I have a question. What do you think about management of recurrence of mictional troubles, voiding troubles after the first mutation of prostate? How do you manage it? Have you got, you want to go first to the medical treatment, or are you going back to the OR instantaneously are you doing the fibroscopy? What is the...
Well, I think in every post-operative, I try to simplify it to residents and younger colleagues. When you have a patient who had an operation, holmium, TURP, open, whatever, and he's not happy, you have to do an anatomical evaluation and you have to do a functional evaluation to understand what's going on. The anatomical evaluation can be a cystoscopy, for example. You can see if there's a stricture in the bladder, if there's a stricture in the bladder neck. You know, these are not very common problems, but sometimes, of course, we see them. And then you have to have a functional evaluation. So I would do a urodynamic study to find out what's going on with the patient. I would say that with enucleation, the big majority of patients do well after maybe, you have secondary hematuриas, you have small problems, retention, postoperatively, small problems in the postoperative moments, but most patients after 3-4 months tend to be really well, unless they have this kind of problem. I don't know, maybe there's a nodule, remaining that can behave obstructively. But I tend to think like that, anatomic evaluation and then functional evaluation to see what's going on. So another problem is the hyperactive bladders. Some patients, maybe 1 or 2%, they don't recover a normal bladder function after enucleation, and then you have to resort to Botox or something like that.
Actually, I was talking about
For the online
I was talking about the long-term recurrence, or perhaps 2, 3, 4, 5 years, or 10 years after enucleation. Have you got some remarks on that? What I see is that I would like to have your feeling about that. It seems that there is a capsule retraction after HoLEP or all enucleation. And it seems that if you have a recurrence with prostate nodules inside this retraction, you're going to go to obstruction very quickly. I saw that medical treatment is not enough for these guys. And usually there is just a small recurrence. And when you go back to the laser and you treat them, sometimes with a small nodule, you have a very good result. And perhaps I would like to know.
Yes, that's why I insist that you should be very thorough trying to remove the nodules, because if you leave nodules, I remember when we did open prostatectomy, you would feel the fossa with your finger to see if there was an adenomeric nodule, remaining, because this could be a cause for recurrence. But this can happen, and of course, if there is a mechanical obstruction and the patient is obstructed, you have to go back and do it, which is probably easier. We see this with open prostatectomy. We see this with TURP. Of course, more often with TURP than other enucleative procedures. But this is the anatomic and then functional, and then you decide what to do.
Any more questions?
Okay, and just a comment in the previous questions, because we have people that are in new colleges and maybe we would like to be more specific in our answer. I would like to say to the new colleges that when you have an urethral stricture, the problem is anatomical. when a patient has BPH, the problem is functional, not anatomical. It's not just an obstruction. If you have recurrence after enucleation of the symptoms because of the capsular retraction, this is anatomical, not functional, because this area is already denervated from the previous surgery. So, just my comment.
So, Fernando, thank you very, very much. Meeting you was really a pleasure and an honor several months ago.
It goes both ways.
And a really important moment of my professional life and personal life. So just a question, because we know that in Greece it's not a long time ago that we started doing HoLEP. What would you recommend to a young colleague that he wants to start? Because we know you're a pioneer. You did the apical release, early apical release, you did the M-block technique. But what I did for the first time was the 3-lobe technique. And I thought that it was much easier, but very time consuming. Do you think that we need to start from 3-lobe technique and then go to M-block?
No, I would recommend to start with M-block right away. What I do to teach my younger colleagues is to do the apical release myself first, and then let them complete the operation. So they get proficient and dissecting the plane, and then they start doing morcellation like that. And then as they get better in the second part of the operation, and then I let them do the apical release, because of course, when we teach this procedure, we don't want the patients to pay for it. No, and I think it's a safe model to learn M-block. I think M-block is probably easier than 3-lobe. 3-lobe is very confusing. So I push M-block, yeah.
Okay. And having a mentor, we cannot start just looking videos.
Definitely. I got a lot of messages from people who watch my videos, and one guy from the States told me he lost 10 kilos watching my videos because he would use the static bike, watching the videos for hours and hours and hours. But again, when he started doing M-block, his surgical time went down, his rate of incontinence went down, so I think it's really something that needs to be pushed. The best way to learn is to go to a center where they do a lot and stay there for some time to really understand what's going on. You have to see the big prostate, the small prostate, the inflammatory, the good plane, the bad plane, the bloody prostate, and you have to see how this is handled. And then you understand and you're ready to face these complications yourself. The problem before was that the videos were highly selected. So you saw a video and you thought, this is amazing. And when you try to do it, it doesn't look the same. It's very confusing. So the more exposure you have to the procedure, the more you do. In Bulgaria, there's one guy, Dr. Georgiev. He doesn't know how to do a TURP, but he has been with me doing HoLEP, GreenLab, HoLEP for many years. Now he does an amazing HoLEP. He's super fast. He's an amazing HoLEP surgeon. He never did a TURP, and he learned M-block, of course. So if you understand the procedure, you can do it even when you don't have a lot of endoscopic experience.
And just to add something small, you have also to convince your equipment that you are using to work at the specific time, because if you are inexperienced, usually the first thing that you have to deal with is that things are not working. So you need the experience to convince the laser to work. Usually it's the less problem, the video to work, and the morcellator to work.
Yes, definitely.
Thank you, Fernando. You give inspiration. Thank you very much.